she so rightly said. But just to highlight for those of you who don't know her, this writing is really small. So Nancy is a distinguished James McGill Professor here at the Department of Medicine in Clinical Epidemiology. She originally trained as a physical therapist, and she holds a PhD in Epi and Biostats and leads a research program on function, disability, and quality of life in Canada's vulnerable populations. And methodologically, she specializes in measurement of health outcomes, design and analysis of complex interventions, and optimizing methods. She has published more than 350 scholarly work, and her first trial was in 1981, and she has conducted and participated in more than 25 trials to date in complex interventions. Thanks so much, Nancy, for being here. Should I pass this?
Yeah, I think so. Thank you. Let me see that I can turn this on the right way. Yes, well, thank you very much for inviting me. It's a great pleasure for me to do this. This is one of my favorite topics, and I had a lot of fun putting together the slide deck, so I hope you will enjoy it. So I'm going to talk about the what, why, where, and how of complex interventions. So you have to keep those 4 words in your mind, and at the end, we'll make a recap and see how many boxes I checked. So if I have to start with a conflict of interest, and one of the complex interventions that I will give as an example tests a digital health technology that's being commercialized through a McGill spinoff company, of which I am president and co-founder of Physiobiometrics Inc. And just to let you know, conflict of interest. So let's start with what are complex interventions. So simply put, complex interventions have several interacting components. But of course, there's more to it than just that. So they're complex because of the number, variability, and difficulty of the interacting components, both for the experimental and the control group. This is one of the areas where designing the control intervention is far more difficult than the actual intervention. It also the complexity and the difficulty of the behaviors required, not only of those delivering the intervention, but those receiving the intervention. Also, there are usually more than one organizational group that are the targets of the intervention. This is usually the participant. It can also be the care partner, healthcare provider, and the care context can also be targets of the intervention. The outcomes, by definition, are complex, and the intervention is usually tailored to the person's specific needs. There is no one size fits all. So to be effective, a complex intervention has to demonstrate that the components can be effective in everyday life. These are not interventions that are done in a petri dish or in a lab. You need to demonstrate their everyday life effectiveness. The whole range of effects of your intervention and how they may vary among recipients or between sites need to be shown. And you need to demonstrate how the intervention works. What are the active ingredients and how are they exerting their effect? So they're a little bit different because you have to have these 3 elements as part of your evidence for the effectiveness of the intervention. So here's some examples of complex intervention. Anything that's community-based is usually complex. Anything that involves groups is usually complex. School-based interventions, clinical teams, clinical units, cognitive behavioral therapy, hospital at home, service delivery interventions, healthcare professional behaviors, health promotion, complex interventions, digital health technologies, and most rehabilitation. So why do we need a different paradigm for a complex intervention? So when you have a complex intervention, you're trying to meet the needs of a particular group of people, and they are usually highly variable and have different needs and expectations. You design the intervention to meet these people's needs. They have to help you with that. You don't know what their needs are. You haven't probably, hopefully, have not had the lived experience of that health condition that you're studying. So you have to engage not only the literature and the scientific community, but the people with that lived experience to tell you what the intervention needs to be. Then you evaluate that intervention using pretty standard methods with maybe some additional methods for complexity against the same population or a typical population. And you have to come back to those same needs that they already expressed. A more standard evaluation, more that kind of pharma model, and we're not going to say a simple intervention. There are no interventions that are simple. And the complex intervention literature says it's not a binary, simple, complex. It is a bit of a continuum. But the standard clinical trial paradigm is I'm evaluating something, emphasis on evaluating the person, and I'm picking perfect people to evaluate the intervention. Rather than I'm trying to meet the needs of a complex situation, I need to design that intervention based on their needs. So it's a different model. So while the intervention's complex to design, what the control group gets is even trickier. So what are the options for a control group in the context of a complex intervention? Well, one is you give them nothing, all right? Well, you know, in the real world, we pretty much have a lot of experience that nothing pretty much does nothing. But that is an option. You could use usual care. Sometimes, though, usual care is inferior. And if usual care is inferior, that can jeopardize your trial result because the people are not going to be in your study when they know they're not going to get anything worth spending their time on. Can't do placebos. You can't do sham. Active alternatives work. But you have to be quite creative as to what is the active alternative. What seems to be the more, I wouldn't say simplest, but the perhaps easiest way of thinking of a complex intervention is hit it with a big stick or hit it with a bunch of little sticks, or a lesser stick. Sometimes this is actually called a dismantling trial. Don't know whether you've heard that term, where you have a lot of, you test an intervention and you might have multiple groups. Some gets everything, some gets lesser and lesser and lesser. So these are our options for the control group, but in my experience, we've spent more time designing the control group. And that's where it's very important that you understand what your active ingredients are. So with this complex intervention, you have to be very neat and tidy in describing your intervention. And this is why we have guidelines, which are on Equator. And I encourage anybody working in this area, well, I don't encourage it. You won't publish your paper unless you put in your tidier guidelines. So, and there's a template. So the template has, name it. So you have to have some sort of name. Why it? Why this intervention and not some other intervention? What, do you need any specialized equipment? Who provides this intervention? How and where is it provided? When and how much is provided? What is the tailoring? And how well was it provided, looking at both adherence and fidelity to the protocol? So when, as with anything consort and stuff like that, after write down the page, appears. And so that is an essential ingredient for a complex intervention. So complex intervention are by definition patient-centered. You're trying to solve a problem for a group of patients. So this will require a set of patient-centered outcomes, which, apart from mortality, are symptoms, function, and quality of life. So you have to have this range of patient-centered outcomes. You also need to provide meaningful evidence for the different actors in the healthcare process. So a clinician is not going to buy an intervention on a quality of life outcome. They're going to need to see their outcomes there as well. So they need to be there. So it requires not only different sources of information, but all of these sources. I realize this is health outcomes jargon acronyms, but the information you're going to need in your complex intervention falls under what we call PRO and SRO, patient-reported outcomes or self-reported outcomes, observer-reported outcomes, sometimes when you're for caregivers, They will report on the observation. Sometimes in clinical settings, a nurse might observe the activities of the patient. Clinically reported outcomes, traditionally clinicians like that. They rate those things on certain scales. A performance outcome is just exactly it. It's performance. It's a test like the 6-minute walk test or a visual acuity test or a cognitive test. And a TECO is something that is measured using some technological advice. Classic imaging is technology, but now in the era of digital health and wearables, a lot of that technology is from there. And there's a whole paper here from our team on how you actually talk about those outcomes. So here's some both non-complex and complex intervention outcome models. So I gave you the list of the outcomes you need to cover. So there's 3 models for interventions. One of them is the target. So the intervention is specific for one outcome. Others may be measured, but they do not contribute evidentiary support. All right, you're in the legal speak now. What is the evidence? You measure these other things, but the only evidence that is presented for the trial or is considered for the effectiveness of the trial is on the targeted outcome. There are other intervention models where it's a domino. So you fix one thing and everything else falls into place, miraculous. That's what I think we hope for. Improvement in the proximal outcome is the evidence. The other outcomes are this cascade of downstream effects support the relevance of the intervention, but they're not part of the evidentiary support. They support the relevance. Not only I fixed this, and look what else I bought with my intervention. What is typical of a complex intervention is a fan. The intervention simultaneously affects many outcomes and each contributes evidentiary support. And this is why we need different models to deal with this outcome, this more complex set of outcomes. So because of this, you need to have a strong measurement model. You can't just use what everybody else uses. You have to justify based on theory what is the model. So here's some models that are used. There are many others. You don't have to use these in particular. In the medical model, the one in blue is the Wilson-Cleary model, was published in 1995, Ira Wilson and Paul Cleary. And this was to try and get the medical profession into the health outcomes world. And it's widely used and is a good starting point, but it also shows you the complexity of outcomes that you need to measure and also the things that drive the outcome. So for example, characteristics of the individual, you have things like personality, symptom amplification, values, and preferences. The one below in white is more familiar, certainly in the rehabilitation world. This is the World Health Organization's International Classification of Function, Disability, and Health. And it illustrates that certain body functions and structures affect what people do, and that affects their roles that they're able to play in their life, affected by personal factors and the environment, but caused by the health condition. Here's a nice model here for behavior. This is the COMBI model, which presents that to get a behavior change, you need to understand what the person is capable of, what is their capacity, what are their motivations or motivating or demotivating factors, and do they have opportunities. So this is widely used and it's very useful model. So there's no lack of models, but you have to have some sort of model if you're arguing for funding of a complex intervention. So because of all this complexity, and I have to thank Nandini for this, she describes the complex interventions as trying to fit a square peg into a round hole. The complex interventions, by definition, have all these nuts and bolts and craggy pieces and elbows, and you're trying to put them into this very nice classical clinical trial model. which is often based on the one ingredient RCT pharma trial. So it's a bit of a challenge. So this is from the BMJ article on complex interventions. There's a literature on it. Look it up. They have two articles, an earlier one and then a later one. And they talk about the sequential phases for developing a trial of a complex intervention. So it starts with the sort of preclinical. It essentially starts with theory. You have to have some theory as to how the world works. You also have to have observational data that theory works in the real world. Doesn't have to be your own observational data. You can support it from the literature, but the bits and pieces of your theoretical model that's driving it has to be backed in theory in the real world. Often there is an exploratory trial that is done. These can come under different names. There's proof of concept and there's pilot, and they're all quite different. Then you can do your definitive randomized trial, but in the long run, it has to be implemented because these are designed to be implemented. So I think I simplified that. So these are the steps. What theories apply to inform the intervention? So these are the theories for the intervention. What do people living with the targeted health situation say needs to be done? This is the participatory research. They need to tell you what needs to be done. What observations support the hypothesized links between the intervention components and the outcomes? So that's when you're doing your literature search, you're looking at literature for those arrows in your diagram. What is the literature supporting that? You can do a proof of concept study, and then you can do a pilot and feasibility study, and there are reporting guidelines for pilot and feasibility studies. And again, if you're doing one, you're going to need to fill out that consort extension for pilot and feasibility study. And I noticed that the trial network is running pilot and feasibility studies, and I suggested in the call that they'll have to do that, as opposed to make it up themselves. Just follow the guidelines. You need to have the trial adequately powered for all outcomes. You have to have an implementation plan. And at the end, you need to have both participant and the interventionist debriefing. They need to tell you how it worked, what didn't work, why it worked, because that will allow it to work in the real world. So that is a little bit more of a summary from a mix of the data from the studies, the articles on complex interventions, and my experience. So I'm going to give you a couple of real life examples. So this is not mine, but this is one from the New England Journal of Medicine. And that was one of my first sort of adventures into trying to communicate trial complexity. And this was done in the context of I went to China with Jeff Drazen, who was the editor of the New England Journal of Medicine at the time. And he wanted me to come to talk about clinical trials because he said, you talk plain language. You know, I say, what is the question? What is the outcome? How is it measured? So one of the studies that I demonstrated was from this. And here's the question, and it's written in a PICO format. And by the end of this class, if you can't write a PICO format, I'll have to hang up my teaching license. So they, of course, didn't write it like that. There's no such animal as that in especially the year that was done. So among persons with type 2 diabetes and microalbuminuria, does intensified targeted multifactorial management compared to conventional care reduce mortality from cardiovascular causes and occurrence of 1,000 things, which you can read faster than I can talk them. So this is essentially the model I drew based on what data, what evidence did they present? So you could almost put table 1, table 2, table 3, and table 4. So their question was, does the intensive care management, team management, achieve better outcomes? But that doesn't happen by itself. There has to be a whole bunch of stuff that went on to get those outcomes. And this is why the intervention was complex. It had multiple pieces. So the first thing is that the path was intensive team management made behavioral change in the subjects and management chain in the clinician. There's just not patients involved in this. The clinicians had to change their management. That produced favorable changes in bioclinical markers, and they measured 1 million of them. And that was theorized to produce the data. So if the changes now come. So if you were designing this, you would need to have literature showing each one of those arrows is potentially viable. And then, so that was their path. But the data they presented, they first presented team management on behavioral change, and then they presented the intervention on the changes in biomarkers, which is phase 3. And then they changed the that their final table was on that. But that was the path that underlay their study without them being explicit about it. So the analysis was regression on regression on regression on regression. Okay, and this complex model is better assessed using other things, particularly something like structural equation model. It's rarely done in certainly in biomedical problems, but here's an example of using a proper analysis to deal with a complex intervention. So that was this group. So when you have multiple outcomes, like this one here, with we have behavior changes and we have biomarkers and we have outcomes, you need a better classification than primary and secondary and tertiary and quaternary. You can imagine how that list is going to pan out. One of the statisticians from Colorado working in the area of cancer came up with this classification that I like very much. What is your confirmatory outcome? This is the one that the study is designed to impact and the power calculation is focused on. What are the explanatory outcomes? What outcomes are theorized or known to affect the outcome and will explain whether the outcome was achieved or not? This is very important when you're trying to do things like a behavior change or you know, does exercise change cognition? Well, you got to make sure that the exercise in fact changed, the intervention changed the intermediate outcome, because if you didn't get the downstream outcome, maybe you didn't get the more proximal outcome. So those are explanatory. And then there are exploratory outcomes. The impact of the intervention is not known, what would provide additional scientific value. So the power for all of these outcomes needs to be considered, but should not drive the power of the study. It isn't as if you know, if you need 100 people for the confirmatory outcome and you need 1,000 people for the explanatory outcome, that's not going to happen. Okay, nobody's going to fund that. So you have to address power, but you can address it at, you know, and say, we're only going to do 60% power for these exploratory outcomes. You can't sweep them under the carpet, but you can address it. So be a little bit more creative than just labeling things, you know, primary or secondary. We've moved forward or beyond that when we remember we used to label things single blind, double blind, and triple blind, and all that tells you is how many people were blind. It doesn't tell you who they were. So this is the same thing. So one of the complex interventions I want to illustrate to you was something we did a couple of years, many years ago now, called There's No Place Like Home. All right, lessons learned: do not call your trial something that will give away the hypothesis of your study and will make people wonder why they did not go home when the study was called There's No Place Like Home. But, you know, hindsight's 2020. So here's the PICO. Among people ready for discharge from hospital after an acute stroke, to what extent does prompt discharge combined with 4 weeks of home rehab in comparison to the usual discharge planning process impact on health-related quality of life, which is in there in bold, because at the time when this was written, you would not get funded in CIHR for a trial that did not have a single outcome. I'm not sure we've moved on from that, putting a square peg in a round hole, but there it was. Also community integration and function during the first 3 months after stroke. The primary hypothesis was that in comparison to usual care, the home rehab would shorten length of stay. So that's an outcome at the hospital level, and enhance quality of life or health-related quality of life. Okay, that's a patient level, and community integration without a detrimental effect on recovery. Because the theory was you could only get good recovery if you were in a rehab center and had wonderful therapists running around treating you. How can we send them home? and they would still get the same care. So that was the idea was not to sacrifice that. And secondary hypotheses were that the intervention would cost less, so that's the other outcome, and would not pose an extra burden on caregivers, because all we need to do is shove people out of the hospital and let the caregivers look after them. So clearly that was another outcome. So now this intervention has 3 levels of impact. It has at the health service level, it has at the patient level, and it has at the caregiver level. So I put check marks there because we showed that worked, no problem.
We do have a quick question from the chat from Dr. Dan Panaro. Can you provide a reference or name for the brilliant confirmatory, explanatory, exploratory outcomes?
Yes, I will.
Okay.
It's Diane Fairclough.
There you go.
So what did we deliver here? What was the spoon that we had in our hand to impact on these outcomes? So I often give the analogy of what's on the spoon, to talk about what are you delivering to the patient based on, probably every one of us has at one point given our kids banana flavored or grape flavored amoxicillin for ear infections. And it is not the banana flavor or the grape flavor that is biologically active. It is only the antibiotic. So when we do complex intervention, put a bunch of stuff on the spoon. We don't put one. So what did we offer? So the home rehab group got all these kinds of things. They stayed in the hospital 9 days. The usual care stayed 12. Nobody went to rehab, but 7 people in the usual care group went. So the length of stay was shorter for the home rehab. But the other usual care group, they got therapy too. The reason they got average therapy is because 7 of them got a million things and 49 of them got nothing. So the 2 sample sizes were 58 and 56. So it wasn't amazingly different what people got, but it was driven in the usual care group by 7 people getting a whole bunch and 49 people getting virtually nothing. So we had to look at the cost and the caregivers. So we did find that the costs were much cheaper in the home group, and we did not plug off all of the care in the hospital on the caregivers. The caregivers actually worked much better. They felt much better having the patient home. So how does that work? So good thing we did exit debriefing on our participants. And not only did we do that, our participants spontaneously debriefed us on what their challenges were. So the first thing that we found was that the usual care group was angry at us. They were mad at us because they got usual care and usual care was nothing. And this is because rehab services are really only covered in a designated institution, and that group eventually went home without services or very sad services. This affected their desire to be assessed for follow-up visits. Why should I come back and do your complicated thing when you gave me nothing? Thank you very much. We also found that therapists noted that once the participant was home, there was a power shift from the clinical team to the family team, which was favorable. And they said the family was empowered to take charge of the recovery. Whereas in the hospital, they're very passive. They're very terrified of all this strange equipment and these odd people. So this was something very positive. Now, the nurse who was involved in the team noted that if the patient was medically unstable, she had no one to contact. So this was our nice neurologist on our research team took that up. So I, phoned Joe Carlton. He'd say, just I'll meet the person in the emergency. We had Liam Durkham. We had a bunch of people, Robert Cote. This is not the way the real world works, where you phone your friends and ask them to look after your participants. So she noted that the family physician did not want to manage a stroke patient essentially 10 days after stroke. So the issue of optimal post-stroke management was not resolved. What came next? Bridging the gap. So this was our next. See, when you're in this complex intervention, you don't stop at one intervention trying to solve a problem. We hadn't solved it yet. We still had a mess. So this study was about the effectiveness of teaming a stroke coordinator with the patient's personal physician on the outcome of stroke. Again, the PICO question, among people newly discharged home from an acute care hospital, teaming a stroke coordinator in comparison to receiving care only through their personal physician without the nurse helping them out, impact on function, community reintegration. I've highlighted physical health related quality of life. Again, I had to choose in order to get CIHR funding, I had to have an outcome. I had to have a single outcome, and after 6 weeks and 6 months. So in this study, we took all the very complicated people. We took the people that usually are excluded from stroke trials because these are the people that need to be managed. It's no use, eliminating them. I'm trying to manage their problem. So we wanted first a recurrent, we didn't mind, mobility problem, or they needed post-discharge for complex comorbidities. So the nurse is very good at helping with that. Or they had a cognitive deficit, or dysphagia, or incontinence, because the nurse is very helpful with that. Or they required social service, and we had lots of people like that. So this is real world. This is an intervention that has to work in the real world. So our key points was that it didn't make any difference. It had very little impact on our health outcome, and it had very little impact on health services utilization. The reason is that this was a essentially nursing intervention. They did health surveillance, information, education. It's passive, and it may not be sufficiently potent to alter health status as perceived by the stroke survivor, health services utilization, or time post-stroke. So what was on this booth? Well, this was an article that Carol White, who was on the study, they used a nursing intervention classification. Nurses write wonderful notes in legible handwriting, and we were able to put it into, not me, they did it. And so this is what was on the spoon. Health system, case management, health information exchange, guidance, surveillance. Good stuff, but not enough to change the outcome of a person with stroke. They had 50 different nursing interventions, dependent on need, 3 to 30 home and telephone contacts, on average 6 different interventions, a range of 2 to 15 to 30. So this is the similar, right? So when we debriefed for this study, we debriefed the nurses here. Each patient was unique, requiring a high degree of tailoring. Examples: swallowing deficit as a different set of interventions than somebody who can't walk. Speech deficit, cognitive impairment, incontinence, unstable family, alcoholism, abuse, food insecurity, income security. There were a few classic strokes, but they were few and far between. So this is the population that needed case management, and I had one. So we wrote another paper saying evaluating a complex intervention with a single outcome may not be a good idea. And this was the example from stroke case management. At the time of the study, there were very few outcomes that we would have been accepted in a stroke trial. We needed to have only one. So we had to get away from these basic functional scales. So we went to the SF-36, which was emerging as the priority measure, but it's got 8 subscales. You can't have 8. It has 2 component summaries. You can't have 2. You had to have 1. You flip a coin. So let's see what was on the spoon to change an outcome of. So the nurses delivered stuff that would help with mood and energy and pain. They delivered things that would help with participation, personal, family, and social roles, and with health-related quality of life, but they actually had no interventions for mobility. You need to fix somebody's mobility, you better send in the physical and occupational therapist, not the nurse. So we decided to create a composite index, which was you define the construct of interest, you identify the domains, identify the measures, put them all on the same scale, the binary. We use generalized estimating equations to estimate the effect of the intervention on the composite measure. You interpret as the effect of the intervention on outcome, no matter what you call outcome. If the primary analysis yields an effect, you may unpack it for free. But if it doesn't, then that's the end of the story. So we looked at the proportion making a clinically relevant response by group. You can see the nurse case management was slightly higher on all 7 subscales. We did not include physical function because they had nothing on their spoon for physical function. Nothing overwhelming, but when you put it together in a complex model type situation, the odds ratio for nurse case management was 1.43. So it was an odds ratio of 1.43, improving outcome no matter what you call outcome. So we concluded, I think we're close to the right answer, that the nursing case management is likely effective on outcomes related to emotional health and pain, somewhere between a trivial one and a substantial one. And here's an article that talks about that amount. So I was always impressed with this. This discovery consists of seeing what everyone else had seen and thinking, but no one else has done. And his last sentence is, he is the physiologist who discovered vitamin C, so thank you very much. And he was notable for criticizing government granting agencies, which required minute tracking of things on every penny. And we're a little bit like that in our clinical trials, where everything has to fall into that round hole. Heaven forbid that there is something that slightly deviates from the textbook clinical trial. So I have a few more minutes. I want to do something a little bit more modern. This is where I'm in conflict of interest. Why is digital health technology a complex intervention? Because I stuck it up in my board file, right? So it's because of this. This is the problem with digital health technology. Having a thing is not enough. It's necessary to have a thing, but it's not sufficient. There are a lot of things going around here which are completely useless. So when you're thinking of evaluating a digital health technology, you have to think about usability of the thing, and it has functionality, aesthetics, design, and complexity. And you also have to think of the participants in terms of tech readiness. What are their attitudes to technology? What are their perceived usefulness? What are their perceived ease of use? And what are their skills they bring to the table? So we haven't even done anything in terms of evaluating its effect on outcome. And we already have 8 boxes that we have to have some data and some evidence for. So having a thing and tech-ready people and having a good thing and tech-ready people is still not enough. You have to understand why wonderful people do not adopt your wonderful solution. And you have to provide solutions. So you have perceived usefulness and perceived usability. So this is based on a lot of external variables that you may not even know, so that the literature review you have to look at. You have to measure attitudes, you have to measure behavior intention to use, and then actual system. Yeah. Oh, sorry. Yeah. So this is an intervention that I'm designing right now, and it's based on our heel-to-toe sensor. And as I said, it's our company is commercializing, marketing it. And essentially, it harnesses the power of the brain to provide therapy in every step. So it provides a congratulatory beep when the person makes a good step. And we're trying to improve gait quality, quality before quantity. Can't ask somebody to make 5,000 terrible steps. You will not be doing them a favor. This auditory feedback sets up a feedback loop, which via the dopamine system stamps that more normal pattern in, most likely through neuroplasticity. So we have an evidence base for our sensor. So it exists. We know it produces dopamine, not me. I never did any of those studies. There's a literature, right? I look up all the literature and I can speak to that intervention. Our heel to toe changes gait. We know that. We've done 4,500 gait traces on that. It changes gait. And we've now done trials and proof of concept that changing somebody's gait changes their walking. This was measured in the 6-minute walk test. And changing somebody's gait has the potential to prevent falls. Fine. What about taking this intervention, which we've done in seniors and Parkinson's, and what about applying it in the area of dementia? So what is needed? Well, I need theory. I need observational data. I need target users input. So I need to understand from the target users and their caregivers what they need. I need intervention and control components. I need a proof of concept. I need a pilot study, and then I need a new trial. So the challenge here is that evidence that tech improves walking is not enough. So what? That's not the main problem that people with dementia have. Although people with cognitive impairment fall more than their unimpaired peers, the target needs to include cognition. So here's another framework. It's called Adapting Interventions to New Contexts, the ADAPT guidance. So I have an intervention that was used in seniors and Parkinson's, and now I'm adapting it to a new context. And the argument is use of interventions with the previous evidence base in new contexts might be more efficient than developing new interventions. But many populations are highly sensitive to context. So this is another framework. So this was our model. This is how we perceive that our target, our intervention would work. We knew that cognitive impairment, which is measured, which has all of these elements, lots of them, impact gait kinematics. That's how the joints move during walking. We know that. There's hundreds of articles. I don't have to redo that literature. Don't bother redoing it. It's there. We know that. We know that gait kinematics impacts on falls. There's lots of literature on that. And we know that strength, flexibility, and balance also impacts on falls. We know that cognitive impairment also affects people's walking capacity. They just don't walk as well. They don't walk as far. It may be that they're just not motivated to go for a half an hour walk. They forgot why they needed to go for a half an hour walk every day. It didn't seem to be part of their need. And so we have literature on that. We know that gait kinematics affects walking. We know that walking capacity affects walking behaviors. People who do not walk well will not walk very far. And then we're into the theoretical world that we believe that I think I have my sensor here, will disrupt this path, will improve this path. And by changing the kinematics, will change walking capacity, will change walking behaviors, and the walking behaviors will improve cognition both directly and through learning and reinforcement and practice and through dopamine. So this was our model, and that we had our literature for. What is the question? Among people with early signs dementia, to what extent does training with the heel to toe sensor over a period of time, period of 3 months, in comparison to what? What am I going to pair that to? That's a big mystery. Result in improved gait, walking capacity, walking behaviors, and memory among users, and perceived values to the care partners. If the care partners do not see this as useful, they're not going to help their person they're caring for put on the technology, encouraging them to work. So automatically we have two groups that are being targeted, and we're going to measure it at this time point. So what ingredients are needed? So in the intervention, tech is not enough. It's a sensor and training how to use it. You get instructions on walking training, how to walk properly. You have to have infrastructure to improve gait. Infrastructure, I mean the body's infrastructure. They need to have balance, flexibility, core strength, and peripheral strength. You have to have caregiver support. That meant we had to include some exercises. People need a reason for using it. They have to have a goal. Why should I put this on their foot? They need to have a goal, and they need to be able to keep track of for us too, we need to be able to keep track of how much they walked and other activities they did. So the control has to get everything but the sensor. That's always the rule of clinical trials. The control group has to get everything but the active ingredient. And that's why you have to know what all the other ingredients are. So fortunately, we had developed a calendar. Adrienne is laughing because she bought 4, I think. And essentially, it's a goal-setting activity calendar, and it has all the exercises. So everybody gets that. And then and they get instructions, on how to, to do specific walking. But now the heel to toe group only gets the sensor and the control group doesn't get the sensor. And the hypothesis is the heel to toe group will improve because we know it. So now I've just changed the question and I've just added a comparison group. So here's a few lessons learned from my early complex interventions. They're difficult to mask or impossible to mask from the participant. So in the absence of amnesia, the patient knew to which group they were assigned. You need to have a range of outcomes that reflect the person's perspective, as well as those unaffected by unmasking. So you have to have something that is a 6-minute walk test, step count, something that is not affected because the person knew what group they were in. So no place like home, the person knew they were in the control group because they didn't go home. And when they got home, they had nothing and they were mad at us and they scored everything badly, or they couldn't. So you need to have the PROs and the SROs, but you also need to have some sort of performance or tech. So it's difficult to design a trial of a complex intervention such that each intervention, this is the next rule, right, of clinical trials, each intervention has to be equally attractive to the naive observer. So I've learned that I write the consent form first to see how can I enroll a patient into this study without giving away the hypothesis that there is one group that's likely better than the other. If I can't write a consent form to get a patient into my study, I can't do that study. So I try to word the study as comparative effectiveness. Who does better, best with what intervention? I usually describe the control group first. I say, if you're in this study, you get this wonderful controlled intervention. I make it look attractive and I have sensors on your foot. If I can't write the consent form, I can't do the study. So that's learning by having to follow your consent form has to match your protocol and you give away the whole thing. So the bottom line is evaluating complex intervention with a single outcome is not a good idea. Trying to fit the complexity associated with interventions that are designed to meet the needs, capacities, and expectations of people living with the health situation under study into that standard round hole RCT paradigm, and we need a new way of doing it. So here's some new paradigms. So there's complex interventions. You can look that up. The ADAPT. There's trials within trials. There's trials within cohorts. There's multiple randomized trials. There's adaptive trials, step wedge. There are other ones, and I'm sure there will be some new ones coming down the pipeline. Not one of these is a round hole. So here's a few resources. There's a literature on complex interventions and the ADAPT trial. Equator has 9 million reporting guidelines for many different types of trials. That will provide you with a toolkit to design. Don't just wait till you're reporting your study. Go look at these before you design it because you won't collect the right data. Tidier, there are many consort extensions. The ACT group is, McGill is here to help. So for example, there is an extension if you're using patient-reported outcomes in your trial. So if you're planning on using, health-related quality of life, look that up. So I think I did the what. I think I did the why. I think I did the how, but I didn't do the where. So we showed that there's many intersecting components. Why? Because fundamentally, you're trying to meet the needs of a group of people. The how is you have to have theory and observations and input and pilot studies and things like that. But the where. So where do we do these complex interventions? So they can be done in the healthcare system, in a hospital, a clinic, a community, a person's home, or virtual. Many trials are now going completely virtual, which will add another layer of complexity. And Tanya's here, she did a virtual trial. I'm doing a virtual trial now. And we have to think of the where. But I think we're up to the challenge of doing these complex where. So thank you for asking me to do this. I had fun. Thank you.
We do have one question from the Zoom so far. When adapting the sensor to a specific population, does it have to be group specific? For example, Parkinson's group walk differently than a dementia group?
Ah, excellent. Good. So our technology is so smart that it detects how well you walk and adapts to your walking. So before who's used it? Oh, a couple of people here have used it. Before, the therapist would have to set, you only get a beep if you get a good step. So we would set it, say, somebody like me, we'd set it at angular velocity, 150 degrees. So some bigger person here like Aaron, we would set it a little higher. And you only got the beep if you pass that threshold. So if somebody with Parkinson's, we'd have to set it at 50. So now our new sensor detects your pattern, and it dumbs it down until you get response. So it already adapts, because you have to get the beep. It's like gambling, right? You have to win at the slot machine.
Well, that sort of answers the follow-up question from someone else, which is, could the control group receive the sensor without the beep?
Yes, it can, but they're expensive. But yes, they can. Absolutely. But they're expensive.
Thank you, Nancy. That was really amazing. I submitted a application for CHR, which I consider to be now a complex intervention. Should have consulted you ahead of time.
Oops.
So my question actually is, and you, I think, did such a nice job of really focusing on sort of the control group, which I always find to be a challenge in these types of trials.
Yeah.
And sort of framing it as a comparative effectiveness for patients, because they really like to know they're getting something rather than nothing. So just though in some of these trials, I wonder, how do you control for the amount of interaction with the healthcare team that sometimes some of these interventions, you know, it's sort of embedded within the intervention, right? To get like that New England Journal of Medicine was intensive. So what is the control group to sort of, you know, also mimic some sort of interaction with the healthcare team, just so you don't get differential, I guess, increase in motivation maybe in one group, which may influence other health behaviors.
Right.
And the other aspect of that, I guess, is you may also get differential dropout rates.
Right. Except it shouldn't probably affect whether you had an MI or not.
Right.
So that's the safety in having something that's not affected by this stuff, that is only affected by what kinds of interventions a person got. You can't wish and hope away an MI. But this is where theory is very helpful. And you need that to be able to show how it works. So for example, I mean, you know, many of you are far too young to know about the first trials of stroke units. So in the days when stroke was just an annoying condition and nobody wanted to treat them, they got stuck all over the hospital. And what happened was that there was a movement for, you know, creating stroke units. And so they created them and they did trials of it before they even knew how they worked. And there's a famous study called Unpacking the Black Box of Stroke Units to find out what actually were the active ingredients. So now that we know that, is that you have to think about all those active ingredients and you need to put a measure on them. So if you think it's motivation, then you put it in. So that allows you to take it out of the clinical trial world and put it in the real world. But it's not only, you know, the trialists did, when we ran our trials at the old Royal Vic Hospital, right? We had the Ross coffee shop. I tell you, those ladies who served lunch at the coffee shop were the most effective people, because they fed these elderly people, they helped them, you know, they looked forward to coming and having their tuna fish sandwich and their chocolate milkshake at the Ross coffee shop. That was so much more powerful. I had a taxi driver, because we couldn't hire taxi drivers for our one of our studies, because taxi drivers cannot legally get out of the taxi and help the patient with stroke down the stairs. We hired our driver. He picked everybody up. Nice young man in his early 30s, was so embarrassed at having to be picked up by an elderly man and driven. And he said, you know, I used to take the bus and everything. The man taught him how to take the bus. He was in my control group. And he drove him to the bus stop. He helped him on the bus. He followed the bus in the car. When he told him to get out of the bus, he picked him up from the bus and brought him up the hill to the Royal Victoria Hospital. So these are unintended consequences of real life, and you just have to ask about them. But you're describing something that's part of the intervention, but does not affect the outcome. And your safety is, I have an outcome that's independent of these things, but it sure helps how it works. I motivated the patient. This is great. They probably had increased compliance or adherence.
Great, thank you. Anyone else?
So the first one says, thanks for an amazing presentation. Can you discuss about the research team components? Dr. Mayo, what role each team member and act in the conceptualization phase?
Right. Yeah. So I don't, again, hanging around McGill for such a long time, you see how McGill evolves over the decades. But one of the things that McGill also was better at than other universities in the early decades, talking about the 70s and the 80s and the 90s, was they were better at team approaches than some of the other medical school type places where you might have had a team of cardiologists all did a different part of the heart versus these multidisciplinary teams. And my mentor was Sharon Wood-Daphne, and one of the things she would always say when you design your study is line up your ducks. Go and identify every single type of person you need in your study to make it effective. And essentially that's what I did. So if we needed nursing, we got nursing. If we needed, and I ran my trials out of 3 different hospitals, so I needed a stroke neurologist in each different hospital. So everybody has some role in one part of either the theory or the interpretation or the recruitment of patients. So, but I can't remember now, but the bottom line is line up your ducks. Get every single person on your team that you need.
The next question is, in making our casual inferences, would it just be based on the confirmatory outcome, or we can be confident to make that inference across multiple outcomes?
Right. So this is where, you're deciding, first you have to decide, is your intervention a target? I'm targeting this, I don't care about anything else. Or is it a domino? And then in which case the downstream outcomes are relevant, but it's only the main outcome. When you have that sort of fan approach, you have to identify the construct that you're trying to improve. So if you're trying to improve mobility, then you might have a self-report measure of physical function. You might have a timed up and go. You might have a gait speed. You might have a 6-minute walk test. You might have a step counter. But the construct is mobility. And so the evidence is for mobility, although you measured it with 6 different measures. So it's at the construct level. It's a latent variable. So you have to think more of something being a latent variable. And that's the evidence is for that latent variable.
2 more questions. Second to last one is, if the control group doesn't receive the sensor, how will their gait quality be assessed, since we would have that information for the intervention group?
Yeah, well, you have to assess them pre and you have to assess them post.
Okay.
Yeah.
And then the last question from Dr. Easer, can you discuss how to approach a complex intervention that doesn't work? Is there a framework for this if you want to publish a negative intervention?
Yes, well, I had a negative intervention, bridging the gap, right? It didn't work. So you have to understand why it didn't work. You have to publish these results. I mean, like nurse case management was touted as the most wonderful thing in the world until I went and said, what are they delivering on the phone here? They don't have anything that's going to change, mobility. So, you have to, but I think you need to unpack what is being delivered. So I think, maybe, you could do it in retrospect. What actually was delivered? Did all of those elements actually get delivered? Was it a failure of fidelity? Was it a failure of adherence rather than a failure of the intervention? If the intervention failed, perhaps your theory's not right. And, theories are, I used to say the theories are for people who don't have data. So, once you have data, then maybe you're revisiting that theory, that maybe the theory failed. And there's some very classic examples of theory driving an intervention, and the theory failed, the intervention failed, and they discovered that that theory didn't work.
Sasha Bernatsky suggests to Dr. Easer that you could add a focus group component to try to understand the failure.
Absolutely. And that's the debriefing. You do that debriefing of your people. Absolutely.
Thanks again, Nancy, so much. That was really incredible. I learned so much. Hopefully the rest of you did as well. And hopefully the rest of you join our next ACT rounds, which Amanda will be disseminating. Thanks again.